Very good morning to all. I am Dr. Saravanan Kumar, the National President for Society for Emergency Medicine India, and I also represent International Federation for Emergency Medicine as its chair for the Quality and Patient Safety Special Interest Group. Without further delay, let's move on for the presentation. I'm going to talk a little bit about the origins of the IFEM Quality Framework, introduction of this framework. What should patients expect from all our emergency departments? What are the barriers and enablers to quality in emergency departments? How do we manage crowding in emergency departments? And what are the quality indicators we need to focus on? The IFEM Quality Framework was first formed in 2011. Later, it was updated in 2018. And the current version of the document is available in the website in IFEM for all of us to refer. And it extensively uses the WHO Emergency Care Systems Framework. As we all know, the WHO Emergency Care Systems Framework talks about three core things as emergency medicine chain. One is outside the hospital, which is at the scene, where there is a provider, a bystander, who is involved in the patient care, and the patient is now transported in an ambulance service, where the care is continued to provide during the travel. And now the patient is handed over to an emergency department once the ambulance services reaches the in-hospital system. So the quality of care and the patient safety has to be ensured across these three core areas of a patient care journey to an emergency department. And we're going to look in the forthcoming slides what is expected of all of us. So what is the focus of this framework? It's to employ a systems approach driven by metrics. There are certain financial drivers involved for quality, accreditation standards, training status, and medico-legal concerns. So these were the core focus of this IFEM standards, and there are recommendations based on the same. So what patient should expect from an emergency department? There are about 8 patient rights IFEM has identified that each and every emergency department patient can expect. That includes, 1, the right personnel. Everybody has to see the right doctor and the right emergency nurse who are emergency trained to manage such situations. Right decision-making in case of an emergency by the right personnel at the right time. Right processes within the emergency department. There are clinical processes and administrative process, but right process at any given point in time. Right approach to evaluation, diagnosis, and disposition. A right environment where the patient is being treated based on the level of acuity of care required and also based on the clinical symptoms. And also the right place where eventually the patient is getting admitted and at the right system based on the level and category of the patients. And of course, the right support systems, which involves other areas like radiology, laboratory, and other support services. So these are the 8 fundamental priorities or rights every patient who gets treated in an emergency department can expect. And other extended priorities include availability of expertise in critical care, early access to any specialist in IP or in the OP setting, appropriate duration of stay within the ED, and development of any other additional services required based on the time and need. So there are certain enablers and barriers to quality in ED. And as leaders of emergency medicine, and every single one of us attending this event should look at what are those enablers and what are those barriers, and also look at how do we improve or encourage those enablers and reduce the barriers. So with regards to the staff, what are the enablers? As you can see in the right side of the slide, which is marked in the green, these are enablers to quality. Clearly the trained and qualified staff. Ensure the emergency department staff are appropriately qualified and trained to handle acuity of patients whom they receive. And training is a continuous effort, and we should focus on continuously training and retraining and upskilling all our staffs, including doctors, nurses, paramedics, and everybody in the emergency department. And training alone is not sufficient. We need to keep them motivated to deliver high degree of effective, efficient, and patient-centric care. Motivation can come from many things. One is from satisfaction of the work itself, appreciations, and also proper incentive or salary mechanisms. And we should be compliant with all the guidelines. All the staff should be aware of both regional and the international guidelines which are applicable and implemented in the ED. And it has to be all inclusive. So your EMS system, your allied health professionals, your nurses, phlebotomists, doctors, all should work as a team to deliver utmost quality and patient safety. Coming to the physical structure of the ED itself, please ensure the size and the number of EDs and the number of beds you have in your emergency department is appropriate to the number of patients you actually handle. And it also goes with the number of staffs you might require per shifts as well. So we need to focus on the space and also the number of people available across different shifts based on the number of patients who visit. Not only that, we need to ensure the place is clean, appropriate, has got very good ventilation and lighting, water and climate control. And make sure all your equipments do function all the times. It's an everyday checking and also relevant mandatory maintenance checkings has to be done, and ensure the calibration of all the equipments are traceable and are appropriate. And the last is the IT systems, where we need to have maintenance and updated technology. And in case if you are using an EMR, we ensure you have a backend support of an IT system, and which is a functioning IT system, which is not burdening you more, but actually enabling to ensure your processes run quite smoothly. When it comes to ED processes itself, there can be multiple processes, both clinical and administrative. We ensure that you stick to all those processes and define those processes and train the people clearly on what are the standard operating procedures and guidelines. And today, there are multiple checklists available and tools available. For example, you can have a checklist for both elective and emergency intubation and the preparation for the same. And there are various tools available for calculating drug dosages. So all those simple available tools and apps can be utilized in our emergency department to reduce errors. Also, please stick to only validated and appropriate national and international guidelines. There are various clinical guidelines available. I'm sure all of us know. For example, the ATLS trauma guidelines, the sepsis guidelines, etc. Look at validated guidelines to implement in the department. And also, how do we manage your throughput or journey within the emergency department appropriately? It's a systems approach. Even before the patient comes to the ED, there has to be a mechanism where there is an intimation given to the emergency team that so-and-so patient has been brought by the emergency medical services or ambulance services to the emergency department, so that you can appropriately prepare your area with adequate number of team members. The entire health system has to be upgraded for the same, and the primary care specialists play a very important role, because those patients who need not be managed in ED or those who are triaged out can be immediately seen in a primary care setting. And ED is heavily dependent on other support services and structures. For example, we need to ensure that there is a support service from other specialist doctors, like neurologists, like cardiologists, toxicologists, trauma surgeons, also unavailable services, for example, radiology services, laboratory services, pharmacy services, etc. So managing any patient effectively in an emergency is an integrated teamwork, and ensure we integrate our emergency departments well with other systems within an hospital premises. And that's not adequate. We have set up systems and processes, but we need to ensure we are delivering safe care. And for that, monitoring outcomes becomes very, very important. We need to set specific outcomes to measure. I'm going to be talking about it in a little while. Monitor using technology, if possible, automate such monitoring so that you can reduce the number of paperwork we need to do in monitoring data. Collect data, analyze that data on appropriate times, and please discuss the data within the team to see where you stand and where you want to improve. And it's always good to have some sort of a benchmark or a target values for you to improve. These are some of the enablers to quality, and we as leaders of EM have to promote such enablers. Another important aspect in an emergency department is to reduce overcrowding to provide quality of care and appropriate patient safety measures. Overcrowding is very, very dangerous in any emergency department and compromises quality and patient safety. As you can see in the pictures clearly, the first picture depicts a fairly reasonably empty emergency department where there is space to receive new patients and there are no much waiting on borders. And this is where we like all our emergency departments to be. But unfortunately, most of our EDs fall into the second bucket where you have a lot of onboarders waiting and you have people getting admitted in different wards other than where they should supposed to be going. So these things compromise quality and we need to put in efforts to improve overcrowding. And overcrowding is just not an issue of emergency departments. Clearly, the entire healthcare system, the emergency departments, the hospital administrators, all of them have to work together to improve the overcrowding issue in both input, throughput, and output areas. And if we don't do that, clearly the morbidity and mortality is going to be quite high in the emergency departments and it's going to compromise quality of care. So overcrowding is a current threat and we should find out ways to reduce that. And we talked about setting outcome measures, but how do we set outcome measures? We can see the IFEM's aspiration, which is the right patient to the right clinician at the right time, at the right setting. So how do we measure now? The quality of care can be measured across 6 or 7 buckets, namely on the effectiveness of the care provided, whether is the care provided is patient-centric, timeliness of the care provided, safety of the care, efficiency, and equity. How do we measure each of those? For example, how do we measure safety in the emergency department is to look at or analyze the incident reports, look at incidences of hospital-acquired infections, medication errors in the emergency department, and violent incidences. To see the effectiveness of our systems and processes, we can actually audit multiple processes, look at standardized mortality rates, look at procedural and diagnostic errors. And to measure how we do well with our patient centricity, you can have a measure of the patient experience or a feedback within an ED, likelihood of their recommending our emergency department, patient's ability to participate in their own care, collection and use of patient-centered, patient-reported outcomes, and things like time to pain or pain management for those who come in pain to the emergency department. So these things will tell us, are we really towards our patients or are we really patient-centric in our departments? The next one is the time-bound care. So many of us understand this as TAT times or turnaround times in our department. There are various turnaround times we can measure based on the situation and also the need. For example, door to needle time, door to thrombolysis time, total length of stay in the ED, percentage of people who leave without being seen, waiting times, etc. So there's a huge opportunity here for us to look at our current timings and also improve our turnaround times. And also to look at efficiency, we can look at number of admissions from ED, avoidable admissions, readmissions, and how good our communication is. And last but not the least, to look at whether are we providing equitable care to all the patients who are coming into our emergency departments, irrespective of gender, age, religion, minorities, and whether they're able to pay for their services covered by insurance or not. So in conclusion, leadership and a culture of quality are critical to sustaining all the activities required for safe and effective care. Leaders must be truly invested in quality and be able to offer opportunities and resources for staff to be motivated in making improvements. A thriving culture of quality is essential to make sure that care that is not being scrutinized does not suffer, and all EDs have an obligation to deliver care that is demonstrably safe and of the highest possible quality for saving our patients. Thank you very much for the wonderful opportunity once again, and I wish you all a great Congress and also a great learning experience, and wish you all the best.